All right, thanks again for everyone that's on the call. So this morning, this afternoon, I'm just going to talk about ocular POCUS, mostly with attention to the optic nerve and looking for papilledema. We'll touch a little bit on like retinal detachment, things like that. What is our reference standard? And that's obviously direct fundoscopic examination. And I feel like sometimes this is how I feel like when I'm trying to use the ophthalmoscope and look in a kid's eyes, that you have a kid that's, you tell them to look straight and they're looking left and right and up and down. And and it's very uncommon that we would ever dilate the pupil. And so you're trying to look through a very, very small hole. And even using the panoptic scans, it's somewhat difficult. This was a study that we did, and we had about 76 subjects. And what we were doing was kids who came in with a concern for increased ICP, like headache, et cetera. Our reference standard was a ophthalmology performed fundoscopic examination. And as part of the study, actually, we asked like, how often did the PEM provider visualize the optic nerve? And this was per the fellow or attending. And interestingly, only 40% of the time did people say they actually saw the optic nerve. And even when they visualized it, 14% were incorrectly classified. And then I will just stress that, now in this era with all the PPE that we're required to wear, with the face shields and goggles and face masks, it's even harder to do. And so I think there's a real potential for us to use ocular ultrasound now to. This is actually a case that I had about 4 or 5 years ago, and I think is one of those cases that, as you know, many of you know, with point of care ultrasound, one of those cases that when you do it, you're like, this is why I do point of care ultrasound. And this was a kid who actually had a history of migraines, who had an 11-day history of a pressure-like headache without fevers and had vomited once. And she was signed out on the migraine pathway. She had received her third-line medication. The plan was for admission to the neurology service for like things like DHE, et cetera. And I remember asking at sign-out if she had normal discs, and she was reported as having normal discs. So this is just to show that this is a normal optic disc here on the left, and this is what papilledema looks like on direct ophthalmoscope visualization. On the right, this is papilledema. And that day actually had a resident who was rotating with me doing POCUS. And so we decided to do this as an educational scan. And interestingly, this is what we saw. So this is again the orbit, and you can see this is the posterior chamber. The optic nerve is this hypoechoic structure coming in, as many of you know. And you can see there's very obvious optic nerve head elevation here into the posterior chamber. And even though, like, when you're looking at the optic nerve, you see how it's somewhat indistinct. It looks like it's probably coming in at an angle. We don't have that clean shadow that you often see in textbooks. There's some weird shadows. It's hard to tell if that's nerve sheath or edge artifact. And we'll talk a little bit about that later. But again, regardless of the optic nerve sheath, you can very easily see that there's significant optic nerve head elevation here. So this is, again, just to compare it to what a normal exam would be. So here, the optic nerve would attach into the orbit, and there's usually no nerve head elevation. And here you can see significant nerve head elevation. And then when we measured the optic nerve sheath diameter, it was wide, 6.5 millimeters, regardless of what number you use. This is clearly elevated. All right, so this was sonographic papilledema, and it clearly changed our management workup. So she got the normal head CT that was normal, MRI, MRV, and then that were also normal, and a lumbar puncture where the opening pressure was actually higher than the manometer could read. And this was a case of pseudotumor. And again, you may think pseudotumor, it's not really that big of a deal, but again, if you just Google pseudotumor, this is the first thing that comes up, pseudotumor lawsuits. And there, as you know, there is potential morbidity associated with this and vision loss, things like that. And obviously, this could have been other things too, like a brain tumor, et cetera. So this is something that clearly, if we had not done this and it was really done as an educational exam, we would totally have missed this. this is the optic nerve coming in. The nerve runs here, the nerve sheath is on the outside of it, and the fluid surrounding the optic nerve is actually contiguous with the CSF space in the brain. And so what we say is that the pressure inside the CSF space in the brain actually is transmitted along the optic nerve. And in normal cases, it'll be normal, and there's going to be no swelling of the optic nerve head. And then with glaucoma, the exact you'll have increased pressure within the orbit, and actually that causes cupping of the optic nerve head into the nerve. And then with increased ICP, that fluid and pressure is transmitted along the optic nerve and optic nerve sheath, and then it causes swelling of the optic nerve head where you see that bulge into the orbit. This is a schematic of the anatomy, and I'll go over this a little bit later in more detail too, but here you can see the retinal artery and vein coming in and diving down through the middle of the optic nerve. This orange stuff is the optic nerve, and as you can see, it comes out and then becomes the retina. There are blood vessels. This here is the lamina curvosa, which is like you can think of it like the scaffolding that's just right at the entry to the orbit through which the optic nerve runs. And a lot of people think that actually this is what potentially causes some of the artifacts that we see on ocular ultrasound. And then you see the optic nerve. The optic nerve sheath is all here, and it's contiguous with the dura and the meningeal structures within the brain. So this is just another way of visualizing. This was a study that looked at comparing MRI to ultrasound and to the fundoscopic exam, and they show you pseudopapilledema and papilledema. So here, what you see on the fundoscopic exam, here's what you see on a B-scan ultrasound. This is the way the ophthalmologists perform ultrasound, and kind of with this image oriented lens to posterior this way. And then this is what the MRI looks like. And in this study, they showed good correlation between the ultrasound measurements as well as the MRI measurements for both pseudopapilledema and papilledema. The technique, I won't go into too much. I think most of you are familiar with this. We want to use a linear high frequency probe. And it's important to use an ocular preset. And the reason for this is that there are some animal studies that have showed there is some theoretical potential for damage to the optic structures, including the lens and the retina. And so usually the ocular presets are set to a low mechanical index of around like 0.2, 0.3, whereas for normal like soft tissue scanning, we are somewhere around the 1.2 to 1.5 range. You want to use copious gel over the eye, and cold gel is preferable because it's a little stiffer and won't run down as much. And some people actually have the patient hold like a gauze to the side of the face, so as you're scanning, some of the gel doesn't run down into the hair and other stuff. Many people use a tegaderm. I'm a little torn, and I haven't quite decided yet which I am. I think the advantages of using a tegaderm to cover the eyes, as shown in this picture here, is that it does provide a barrier between your gel and your probe and the eye, and theoretically, the gel should be somewhat should be germ-free, and your probes should be cleaned well and germ-free. But there's always the potential for that not to happen. I think the problem with using the tegaderm is that sometimes if you're not getting good contact with the skin, and especially if you have a little bit of air underneath, it can cause some artifacts that make interpreting the optic nerve and nerve sheath and other things even that much more difficult. And then usually what people describe is scanning in a sagittal plane or axial plane, as well as a transverse plane. And then there's been newly described a coronal axis approach, which I'll discuss a little bit later. And then the classic teaching is to measure the optic nerve sheath 3 millimeters behind the retina. And this was based on some cadaver studies where people injected fluid into the optic nerve sheath and looked to see where the swelling was most evident, and this usually was around 3 millimeters behind the retina. All right, so this is a picture of an ocular ultrasound, and so the structures are shown here. You have the anterior chamber right here, the lens, the iris, the vitreous body or posterior chamber back here. The retina would be right here along here, and this hypocoque structure is the optic nerve. And in adults, the I think the numbers that are most commonly taught is that an abnormal optic nerve sheath diameter is anything wider than 5 millimeters. In children, it's a little bit more variable. I think the most commonly used numbers are greater than 4 millimeters in infants, greater than 4.5 millimeters in children, and then some people subdivide it between 1 to 15 years and greater than 15. And then after 15 years, they're treated more like adults. But again, as you can imagine, there's some variability in this. So I think the challenges with optic nerve sheath diameter measurements is that the optic nerve in children rarely enters completely perpendicular to the orbit, so it never looks like those textbook pictures where you see that nice clean shadow coming down. And then there's weird artifacts like edge artifacts and posterior shadowing that sometimes it makes it a little tricky to figure out what is nerve and nerve sheath and what's the orientation of the nerve. And then in this particular scanning indication, the orientation of the orbit, like where the person is looking, are they looking to the left or to the right or straight ahead, and how it's affecting the nerve, and then your angle of your probe, all these things can greatly affect the measurements that you might get. And then again, it's not completely well known, I think, because of a lot of these problems with the way people are measuring things, that the normative values truly are not well established. All right, so this is from the Sonocyte website, and you can see that this is a very, I would say maybe a textbook photo of what people describe as the optic nerve here. But in practice, it's uncommon that I honestly see that. Sometimes I think you get lucky and you get something that looks close to that. And even in this example, I would argue that this shadow that goes straight down is probably not all optic nerve, and we'll talk about that in a second. If you look really closely, it looks like it probably is coming in at an angle up here, and you can see there's a little bit of change in the echotexture from here to here. And again, this might actually all be artifact in the nerve head, or the more distal part of the nerve is actually coming in here. This article actually probably was the one that to me was the most convincing to show that what we're looking at and what a lot of people say is the optic nerve is probably not. So here, what these authors argue is the optic nerve is here marked in the A calipers. You can see this hypoechoic structure coming in at an angle, coming up and inserting here into the posterior chamber, and then you can see that there's this thicker shadowing behind, which they're measuring as B. And you can see if you did your measurements here versus here, you can obviously get very significantly different numbers. And what these people argue is that this measurement in B is actually the artifact created by the lamina curbosa, and is actually an artifact and not the actual optic nerve or nerve sheath. And I would probably argue in this particular example, the nerve sheath is actually probably this very indistinct, but you can see this darker line coming down here. And then here, I believe you can see it somewhat right here, right behind the optic nerve. All right, and then this article actually is probably the most convincing to show me that what we're measuring is what we think is the optic nerve may not be the optic nerve. Here you can see that if you remember back to that one picture I showed of the anatomy of the optic nerve, where the central retinal artery and vein actually run down through the middle of the nerve. Here they actually these authors actually put Doppler to try to find the course of the optic nerve, and you can see that it actually comes down and takes a turn. And this, I think, is in line with what a lot of people say, is that the optic nerve, especially in children, takes a somewhat meandering course and is not, straight back as some people think, going straight back from the posterior chamber down to the into the head. Here's another example that they're showing that if you were to measure what is probably more of the shadow, you might get a significantly different measurement than what if you are actually measuring perpendicular to the axis of the nerve. And I think in this example here on the right, what they're saying is the axis of the nerve is kind of in this orientation where I'm showing my cursor, and that perpendicular to that, if you were to measure it, would actually measure 3.5 millimeters, which is normal. All right, so let's take a stab at this. where is the optic nerve? So obviously we see the posterior chamber. I will just briefly mention that there's this hypocoque structure coming down laterally. That's the extraocular muscles, and not to, but you can tell that it's coming laterally and not from the region of where we expect the nerve to be. So the nerve is this thing right here. And if I'll play it one more time, but I don't know if you would agree, but it looks like as I'm fanning through or scanning through, it looks like the nerve is coming in from the screen right and kind of taking a turn in and curving up. And so if we were to measure this, I would probably measure something, the axis, perpendicular to the axis, which is like this, and I might actually measure it perpendicular to it from here to here. All right. So it looks like, you know, if you're using a vertical measurement or a transverse measurement, you know, depending on your the way that the person is orienting their eye and the way where you have your probe, and you can get some funky measurements with you know, with that nerve coming in at a weird angle. And but is there a better way to potentially measure this that's a little bit more reproducible? And this was an article that came out in 2015 in Journal of Ultrasound Medicine. And in this one, they actually advocate for something called a coronal axis measurement. And what, in essence, what they're saying to do is, if you can imagine the nerve coming in from, let's say, here up to here, that if you tilt the probe, like tilt the probe down this way so that the angle of the beam is going upwards, you can actually get a cross-sectional measurement of the nerve. And then you and because you're getting a cross-sectional measurement of this, you're not measuring at weird angles, you should be able to get a more reproducible measurement of the true optic nerve width. I would say that in practice, it's a little bit tricky to do. The way I usually do it is you start kind of along the inferior orbital rim and you kind of push it along in and then just gently tilt it up until you have that optic nerve come into view. It can be a little bit more uncomfortable as well. If you're not careful, you can obviously be pushing on the eye. And so I don't always do this. I think if I'm having trouble doing the transverse or axial measurements, or something's looking a little funny, I definitely use this as a bit of a tiebreaker, but definitely something to think about doing if you've never tried it before. All right, and then lastly, I'm just going to talk about optic disc elevation. So this is a kind of a 3D picture. This is using something called optical coherence tomography. And it's basically using light waves to take a picture of the optic nerve. And you can see this nice bump in the optic nerve head. And this is what we're looking at with the ocular ultrasound. And in this particular study, they found that just looking at optic disc heights, they had pretty good sensitivity and specificity. So using a cutoff of 0.6 millimeters or more, that they were 82% sensitive. And then if they used greater than 1 millimeter of elevation, that they were 73% sensitive. So that makes sense. You're using a higher cutoff, so it's a little less sensitive, but they were 100% specific. All right, so which is the right measurement to use? I'm going to take a step back and actually just point this one out, because I think this one actually helped me to think this through a little bit more. So if you look at this first example, this is a normal schematic or cross-section through an optic disc and optic nerve. And so again, this white part is the posterior chamber. This is where the optic nerve inserts into the posterior chamber. And normally the optic nerve would look like this. When you get increased intracranial pressures, I think the first thing that happens is that that pressure is transmitted and usually through the fluid, and that pressure is transmitted to the optic nerve sheath directly behind this area, and causes actually the optic nerve sheath to widen. And in cadaver studies, that effect is actually fairly immediate. So that happens within, I would say certainly within minutes, to hours. I think I had a bit of a misconception that I used to think that the fluid would also then bulge into this area, and actually that is probably not true. What is actually happens is that when you get that increased pressure into this posterior part, what that does is it actually forms almost like a tourniquet-like effect on this area, and actually causes what they call axoplasmic stasis of this optic nerve head that you can see as the optic disc when you're doing fundoscopic exams. exam. And that is actually what causes papilledema. So it's actually swelling or edema of that optic nerve head that you're actually seeing here when you're looking at through the ophthalmoscope. So another way of saying that is that probably what's happening is that acute changes in ICP are manifested more in widening of the optic nerve sheath, and then more chronic changes, again, that timing is not as well known, but it's thought to be within like days to weeks, actually causes this swelling or edema of the optic nerve head. And again, to kind of reiterate that with definitions, so the optic disc is that portion of the optic nerve head that we're seeing when we're looking at it with a direct ophthalmoscope. And papilledema is optic nerve swelling due to increased ICP. So, and then pseudopapilledema is actually where the appearance of elevation of the optic disc or appearance of papilledema, but it's actually not due to optic nerve head edema. And the causes of this are many. The most common is probably something called drusens. If you hadn't heard about that, basically what that is many people have these deposits in the back of the eye, and in kids especially, they're buried usually, meaning you don't see them, and they can become calcified. So sometimes on ultrasound you can actually see them in ultrasound, but they're buried deposits in the optic nerve head that actually cause the optic nerve head to look swollen, even though there's no true edema. There's other things like congenital disc anomalies where the orientation of the way the optic nerve head inserts into the retina actually causes it to look elevated, even though it's not actually swollen and there's no increased pressure or edema. And then of course there's things like peripapillary masses. And then when we talk about the optic nerve head elevation or optic disc elevation, you can actually see this in both papilledema or pseudopapilledema. And as you said, the difference is that usually from when it's in papilledema, it's from true swelling or edema, and then in pseudopapilledema, it's usually things like drusens, where there's deposits or other things that just make it have the appearance that it's swollen. And then the optic nerve sheath, just to reiterate again, is that portion of the intracranial dura that extends down and it surrounds the optic nerve. And actually underneath that is the fluid that is actually contiguous with the CSF space in the brain. All right, so what does the nerve sheath look like on ultrasound? And here, this is probably one of the most convincing pictures that I've seen in the literature for the optic nerve sheath, because as you can imagine, there's edge artifacts might look like some of this, but here you can see it's very much curved. And I would say that probably half the cases that I've done, you'll actually see something that looks like it could be the optic nerve sheath. And remember that this is actually what we're measuring, is the nerve sheath width. So you actually don't want to measure the nerve, which is this hypoechoic structure in the middle that's labeled here, but you actually want to measure the nerve sheath width from this side to this other side. All right. All right, and so to kind of summarize that, the way I think about it is that fluid in the optic nerve sheath probably reflects acute changes in pressures, whereas edema, or what we're looking at on ultrasound as optic disc elevation, actually can take days to weeks. If you have a normal optic nerve sheath diameter with no optic disc elevation, that would be a normal case. If you have an abnormal optic nerve sheath diameter and optic disc elevation, that is probably true papilledema. If you have optic disc elevation, but a normal optic nerve sheath diameter, that's probably pseudopapilledema. So there's probably something there that's causing appearance of it being swollen when there's actually not true edema. I guess theoretically, you could have like a case where you had increased pressure and from like hydrocephalus or whatever, and it caused optic disc elevation, and then you fixed their shunt malfunction, and then immediately did an ocular ultrasound, and the nerve sheath diameter, I imagine, would probably go back to normal, and your optic disc might still look swollen. So that would be a potential case, although I don't know that we would ever, ultrasound in that case. And then if you have abnormal optic nerve sheath diameter with no optic disc elevation, that's probably an acute increase in ICP pressures. In my clinical experience, I always have in the past taught that if you don't see optic disc elevation, you probably can call it a fairly normal study. That's the first thing I look at. Again, I suspect that this one particular instance would be you had a very acute rise in your intracranial pressure that hasn't had time to cause that optic disc head or optic nerve head to look swollen. And then now I'm just going to run through a bunch of cases that we've had over the years, and maybe we'll kind of look together and see you'll see some of the issues with getting consensus of optic nerve sheath diameter measurements. But we'll take a look. So this is an 11-year-old with a headache. Play the left-hand side first. And I guess the first thing I would ask is, what do you think about optic disc elevation? Elevated, perfect. Yeah, I mean, right. I think this one's not subtle, right? So you can see the optic nerve head looks elevated. What do you think about the optic nerve? It's funky, right? I mean, this really kind of looks like edge artifact. I guess it could be optic nerve sheath. It certainly looks like the optic nerve maybe takes a right angle turn in here. Yeah, right here is probably the most convincing right there. It looks like it takes this turn in and maybe even folds in on, it's hard to tell if it folds in on itself. It certainly looks wide though, right? Just kind of eyeballing it. This one was wide, and this actually was a positive case. So this actually was found to be hydrocephalus due to aqueductal stenosis, and this is a new diagnosis. So this is a true case of papilledema. This next case is a 13-year-old boy with a history of headache. So here's the ocular ultrasound. I guess first things first, optic disc elevation, yes or no? Would anyone say no? It's funny, right? I mean, you can clearly see there's something right here, right? There's something, but it doesn't look like the other ones, right? It's very pointed. I mean, there's clearly something there, right? It doesn't look like that other case or the other ones. So we'll say maybe optic disc elevation, and then where's the nerve? I would, let me see if I can pause it and then scroll through. But do you guys get the sense that it's coming in again from screen right in up like that? And then there's this artifact here again. Is that, or not? I shouldn't say artifact. There's something there that's hypoechoic. Is that edge artifact or nerve sheath? My best guess is that this probably is nerve sheath coming in here. Here it looks like there's something that could be nerve sheath, and then right here that would make this nerve sheath. Hard to say.
What's so funny about this lecture, Aaron, is that what you're describing, I've actually, because I don't want to under measure things, I always include that outer shadow so that I'm not undercutting it and not missing things, which is why I've stopped using measurements, because it's always elevated. But now I'm like, wow, this is a much more logical way to look at it. And it's like, it's really very insightful. Thank you for.
Imagine if I have my finger like this and I measure, from here to here, I'm going to get a much wider measurement than if I'm actually measuring perpendicular to the actual axis of my nerve. So in this particular example, I probably would have, the correct measurement probably would have been here to here rather than here to here. And then you can see here in this image, I think it's hard to get an under measurement. It's easy to get an over measurement, but it's hard to get an under measurement. So this one, we got a measurement of about 4.7 millimeters. And this actually was a case of drusens. So this kid had a formal ophtho exam. They did all their things with the OCTs and A scans and stuff like that, and ultimately determined to have drusens. Here's a 13-year-old boy with headache. What do you think about this one? So first things first. I mean, obviously you can see his eyeball is looking straight off to the whatever left, or right, sorry, looking to the right. Optic disc elevation, yes or no? If I pause and scroll through, I think right there, maybe the most convincing. Would people agree? Yeah, right? Something. So yes, we'll say yes for optic disc elevation, and then the second question is, does the nerve sheath look wide? This is a different view. So here, I think we're a little bit more on axis with the nerve. It looks like the nerve is probably coming in a little bit straighter. I would argue this is pretty convincing, I think, for optic nerve sheath, right? Right here to right here. And this is probably the optic nerve. And so we should measure it from here to here, which would clearly be wide. This is 1 centimeter right here. So that would be almost probably closer to 7 millimeters. All right, and this one was papilledema due to pseudotumor and then had optic disc elevation. This was a 12-year-old girl with a headache. Optic disc elevation, yes or no? Yeah, I think so. Some people talk about this peaked appearance of the optic nerve head versus a more diffuse, I would say, or gentle, I don't know, optic nerve elevation. This one, again, it doesn't look like that first case that I showed where, where we argued a little about whether there was elevation or not, but if there was, it looked very, peaked. And then interestingly, the nerve sheath diameter though here, again, here, this one is, it looks like the right eye. You see the nerve head elevation. You can see the nerve, like it probably comes in at an angle like here. So even though we measured it here, again, we probably should have measured it more along this axis. But regardless, I think that would, this actually probably overestimates it a little bit. So if we had done it truly along the axis, we would have underestimated a little bit more. This looks like a fairly normal optic nerve sheath diameter. And this actually was ultimately found to be Drusen's deposit. So again, I guess this one, I just want to show that, that appearance of the optic nerve elevation, I don't think you can reliably use to say Drusen's or not. This was actually a case from like maybe a week ago that one of our fellows did it. It was interesting because this kid had a history of headaches and had some concerning features that they put on the migraine pathway and did a fast MRI. And the fast MRI was actually normal, but they did this ocular ultrasound. And what do you guys think? Yeah, there's disc elevation, right? And this looks like real disc elevation. And then the nerve sheath, to me, it looks like the nerve comes in at this angle. And so maybe we could have done a little bit more of an oblique measurement. But this was, and I would say he probably actually underestimated a little bit, because if we thought that this was the nerve sheath, you probably should have measured from here actually all the way out to here, which would have been even higher. But this was an abnormal optic nerve sheath diameter. So we have both optic nerve head elevation and a wide optic nerve sheath. And so they ended up actually getting a formal ophthalmology consult because of this, who found that the kid had papilledema, and then they ended up doing the whole workup again, MRI, MRV, and on the actually on this, on the full complete MRI and MRV, they actually commented about bulging of the optic nerve head and some fluid in the optic nerve sheath. And then she had an LP under fluoro that had an opening pressure of 37, and so ultimately diagnosed with pseudotumor. So this is another pseudotumor case. This was an interesting case. It was a 12-year-old who actually got transferred to us after a pretty big workup at another hospital. So I'll play it for you. So this kid actually, his story was, he was just really doing this like blinking behavior. And his mom took him to see an ophthalmologist or optometrist who saw papilledema. And so he got referred to the outside hospital and actually got admitted. He had a whole workup done, including like a CT and MRI and lumbar puncture and labs, and Lyme testing and everything. And then they couldn't figure it out, so they transferred him to us. And then in the ED, we did this. And you guys see what's going on? Do you see how, so again, the question is there optic disc elevation? I think everyone can see that there is a little bit of optic disc elevation. And then right here, there's this very hyperechogenic deposit right here. And actually this is I would say like a classic appearance of drusen. So drusens actually can become calcified. And again, I showed you many cases already of drusens already where they weren't calcified, but in some cases, they actually can be calcified. And if you see this, this actually is, these are just drusens. And so, of course, you want to you can have drusens and increase ICP. So you want to check the nerve sheath diameter. I can't remember if I showed it. No, I don't have a picture of it, but the nerve sheath diameter was normal. And so this actually was just drusens, and we were actually able to discharge him from the ED. And he had follow-up with the ophthalmologist later who confirmed that they were just drusens. This was a 5-year-old who had headache and vomiting and was followed by his PCP, and then they referred him to the ED because I think there was an increase in the vomiting episodes. And I'm sorry, this is a poor study, but you can see how this is the tegaderm right here. I think it's, again, creating some weird shadows, and then we're also a little bit overgained, of course, but I think you can still appreciate, right, that optic disc elevation, yes or no, there. You can see optic disc elevation. And the interesting thing about this one was that that particular night was, there was something going on with the radiology department where we could not get an MRI. It was some technical issue. And so the question was, could this patient be admitted to the hospital and get it done, the next day, or be discharged and have it done outpatient? And so we actually used this to help triage to figure out how urgent or emergent the MRI was. And you could, and so because we saw this, we obviously wanted to have the MRI done, and it actually showed acute hydrocephalus from a new, I think it ended up being a glioma. And here, let's see here. So here's the measurements of the optic nerve. So here it looks like it's probably coming in at a bit of an angle. And if we measure from here to here, it was close to 5.7 millimeters. Can use ocular ultrasound for other things like retinal detachment. This was actually done by one of our fellows within the last month or two. So the retinal detachments, they are fixed off the optic nerve. That's how you can differentiate them from vitreous detachments, which usually the vitreous it lines the choroid and just right on the retina. But when it detaches, it bypasses the optic nerve. But when you have a retinal detachment, these are actually attached to the optic nerve, so they are fixed onto this point. This was a kid who came in with vision loss that had been going on for a while and had papilledema. And actually on ultrasound, you can actually see he's got a huge optic nerve, and this turned out to be an optic nerve glioma. And then this was a kid, this is a kind of a fun, does anyone see what's going on? The kid who he came in dizzy and could not open his eyes because he was so, I don't know, the light was bothering him, or he just felt more dizzy when he was looking. But if you look closely, you can actually see it's got pretty significant nystagmus going on. You can tell which direction it's going to too. All right, and then this last case I'm going to show, it was a kid who had presented with weakness, an MRI that showed a glioblastoma, a GBM, and that was about a month prior. It had no hydrocephalus, and so it was being followed by oncology outpatient, getting radiation and steroids, and then was noted to have a worsening upper extremity weakness, and then an impaired upward gaze, and so got referred to the ED. And what do you guys think? Optic disc elevation, yes or no? Certainly, if it is there, it's not impressive, right? And I think we get pretty much through the nerve, and there's really not much to talk about as far as optic disc elevation. But the nerve sheath actually does look wide. Here you can see the nerve coming in at an angle. I'm going to measure it perpendicular to that. We get a measurement of 5.6. And then this kid ended up getting a stat head CT and showed acute obstructive hydrocephalus and had actually got admitted for emergent shunt placement. So I kind of wonder if maybe this was more acute and why. So I guess the take home from this is that you can't totally rely on optic disc elevation. Bottom line for me is that I think you probably do need to use a combination of both optic nerve sheath diameter assessment and optic disc elevation assessment. I think, don't be scared of using ocular ultrasound. I really, even though there are some cases that are, a little bit more subjective and can be hard to interpret, there are many that are very obvious and can even be, definitely game changers. And, especially in this era of COVID when, we're having trouble, maybe properly using ophthalmoscopes, and you want to be a little careful about being right in the patient's face. Consider using ocular ultrasound. I think getting the images are fairly simple. There's a few things with being careful to anchor, and so you're not pushing on the eyeball and causing them to Brady. But I think it can be very helpful. And I think the more you do, the better you get at it, right? As with many things, we do need better studies to better define what it is that we're looking at, and then I think through that to better define the ranges of normals. And that's all I have.